Hello, everyone. Thank you for joining today's overview of the 2022 proposed rule for the Quality Payment Program. During this webinar, CMS will provide an overview of what is included in the proposed rule for the 2022 Performance Year of Quality Payment Program and explain how to submit formal comments to CMS. After the presentation, CMS will take as many questions as time allows. Now, I will turn it over to Katie Moore, Health Insurance Specialist at CMS, to begin. Please go ahead.
Great, thank you. Good afternoon, everyone. Thank you so much for joining us today. I know you all have really busy schedules, so really appreciate you taking the time out to hear from us today about our overview of the 2022 Quality Payment Program proposals that were in the Physician Fee Schedule proposed rule that was recently released. So I am going to try as best to keep things moving today. We have a lot of information to cover, and we want to leave as much time as possible at the end for Q&A. We can get to your questions, and hopefully you all saw a message that went out to registrants earlier that we are extending the end of today's program to 3:45. We have a hard stop at 3:45, but we want to give as much time extra at the end for questions. So we'll go ahead and get started. I'm going to turn things over to Dr. Dan Green to give some opening remarks. He's a medical officer in the Quality Measurement and Value-Based Incentives Group within the Center for Clinical Standards and Quality here at CMS.
Thank you, Katie. Welcome, everyone. It's my pleasure to be here, and we welcome you to the 2022 Physician Fee Schedule Proposed Rule Quality Payment Program webinar. So thank you again for joining. As Katie mentioned, I am the medical officer in the Division of Electronic and Clinical Quality Measures, which is the home, if you will, to the MIPS program in the Quality Payment Program. Thank you again for joining us. We want to review the proposed changes and requests for information that we have included in the recently published 2022 Physician Fee Schedule Proposed Rule. This will affect the Quality Payment Program in 2022 and beyond. First, let me assure you that we at CMS are aware that the challenges stemming from the COVID-19 pandemic and that these challenges continue. Ensuring patients are getting the care they need during the pandemic remains our top priority. We listened to your feedback and limited the number of significant changes to the Quality Payment Program this year. And this most recent proposed rule for 2022, we continue to focus our policies around the highest priorities for the program with the intent that they are less burdensome for clinicians. I'd like to take this opportunity to note that we are continuing to apply the MIPS Extreme and Uncontrollable Circumstances, which we call the EUC policy for COVID-19 for the 2021 performance year. The application is open and available now on the qpp.cms.gov website through December 31st. MIPS-eligible clinicians, groups, and virtual groups can submit an application requesting reweighting of one or more MIPS performance categories to 0% due to the current COVID-19 public health emergencies. APM entities can submit an application requesting reweighting of all four performance categories. In the 2022 Physician Fee Schedule Proposed Rule, we outline a request for information, or what we call RFI, which is in regards to the draft COVID-19 vaccination by clinicians measure. This quality measure is not being proposed for inclusion within MIPS, but it is included in the proposed rule as part of the RFI, or request for information. We also know that the COVID-19 public health emergency has highlighted the widening gap in health equity, and we are committed to expanding patient access to comprehensive care, especially in underserved populations. In recognition of persistent health disparities and the importance of closing the health equity gap, this proposed rule includes a request for information focused on health equity. We are requesting information related to the collection of data and the revision of CMS programs to make reporting of health disparities based on social risk factors, race, and ethnicity more comprehensive and actionable for clinicians. We are also seeking comments on other efforts we can take within the MIPS program to further bridge the equity gap. Last year, in the 2021 Physician Fee Schedule Final Rule, we finalized the MIPS value pathways, or what we call MVPs. We finalized the development criteria for 2021 and future years. The goal of MVPs is to ensure clinicians are participating in the quality payment program in a way that makes the most sense for how they practice. MVPs allow clinicians to participate in MIPS by reporting on a meaningful, cohesive set of measures and activities. To ensure more meaningful participation for clinicians and improved outcomes for patients, we are moving forward with the next evolution of the quality payment program, excuse me, and have proposed the first 7 MVPs to begin in 2023 in this proposed rule. MVPs will more effectively measure and compare performance across clinician types and provide clinicians more meaningful feedback. We encourage all interested parties to submit written comments on these topics. We'll share more information on how to provide the written comments, which need to be submitted by September 13. And these instructions on how to submit your comments will be given at the end of the presentation. Again, I'd like to thank you in advance for your participation in today's webinar. Your feedback will help us as we evaluate our policies on essential components of the quality payment program in future rulemaking. Thank you again. Katie, let me turn it back to you.
Great. Thanks so much, Dan. That was a great summary of all the different areas we're going to dive into deeper today, so appreciate it. Thanks. Okay, we can go ahead and move forward to slide 3, please. Thank you. As Dan mentioned, here's more information on how to comment for the 2022 proposed rule. You'll hear us talk about this throughout the presentation. It's really important for us to get your feedback in settings like this, but we do require formal feedback to be submitted through the formal comment process so that it can be considered with all of the feedback for the final rule. So again, a date you'll hear us repeat over and over is September 13th, 2021. That is the deadline that all proposed rule comments are due to CMS. So you'll see on the screen information on how to submit, and then more details are available in the proposed rule itself. And I'd also like to flag that we will be posting all of the slides as well as the recording and transcript of today's presentation to our QPP webinar library within a week or two after the event, as we normally do. And then we also have a number of helpful resources on our QPP resource library that breaks down a lot of the priority or proposals that we've put out in the proposed rule. But so would encourage folks to go ahead and visit our resource library and download those resources. Next slide, please. Here's just a quick run of the show for today. So I'm going to turn over in a minute to Molly McHarris to go over our future direction of QPP, where we're headed, and where we hope these proposals will start taking us. We'll go over 2022 proposals for the MIPS value pathways that Dan mentioned, our MVP proposals, as well as our APM performance pathway, or our APP proposals. And then we'll go over some traditional MIPS proposals as well as advanced APM proposals, and then touch on public reporting that we've included in this proposed rule a little bit. And then we will round off with our Medicare Shared Savings Program team. And then we'll leave as much time at the end for some information about health and support and our QA. So with that, I will move it over to Molly McHarris.
Thanks, Katie, and thank you again, everyone, for joining today. Let's go ahead and move on to the next slide. Okay, so as Katie noted, I will be talking through some of the future direction of the quality payment program items, and also for a little bit more background as we think about our proposals we've made this year, as well as our comment solicitations. So first and foremost, when we think about the quality payment program, one of the things that we have tried to do throughout the process of the quality payment program is really to ensure that we are listening to our stakeholders and continuing to build a program that meets our statutory requirements, but also is one of value and is meaningful to the participants, the clinicians, and also the patients who the care is provided to and patients who may be searching for a clinician and are using the quality information that's available on the Care Compare tool. I also wanted to highlight that as we move into our upcoming 6th year of the program, so calendar year 2022, we will have fulfilled a number of statutory requirements, including our approach for how we establish our performance thresholds, as well as where we set our quality and cost performance categories. And we anticipate, as the result of these two policies, clinicians will start seeing higher payment adjustments and a more equitable distribution as part of our scoring system. We also, as I mentioned briefly, have a number of requests for information or RFIs within the rule, but there are two I wanted to focus on. If we could go ahead and move to the next slide. And those two RFIs that I wanted to specifically call out are our RFI related to digital quality measurement and our RFI related to health equity. For those of you who have read the other payment rules that CMS has issued, you will notice that these RFIs do look similar to the content that was released for information in those rules. So what we are looking for under our digital quality measurement RFI is we're looking for feedback on ways that we can continue to use the FHIR approach, the Fast Healthcare Interoperability Resources, as we continue to make updates on the movement to full digital quality reporting in 2025. Also for health equity, we are very much interested in methods that we can undertake to further address equity within our programs. So specifically ways that we can directly address health disparities based on social risk factors, race, and ethnicity. So we can provide more actionable information for clinicians and providers of multiple care settings. So again, for those of you who have previously commented under another payment rule, I'd like to encourage you to be sure to share your comments with us again under this rule and to make any updates as appropriate for our clinician care settings. Let's go ahead and move on to the next slide, and I'll just give a bit of background on the quality payment program. Again, most of this should not be new information for the vast majority of you. But in case it is, let me start by explaining what is the quality payment program. And so the quality payment program is a value-based purchasing program that was authorized 6 years ago under the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA. And MACRA did a number of things, including it repealed the sustainable growth rate payment methodology and set forward flat fee schedule updates, as well as updates to the fee schedule over the next few years. It also sunsetted or ended the 3 legacy quality reporting and value-based purchasing programs that clinicians may have participated under, such as physician quality reporting system or the meaningful use program. And it authorized the quality payment program and the 2 tracks under the quality payment program, which include the MIPS track, the merit-based incentive payment system, and participation through advanced alternative payment models. And let's move on to the next slide, where I want to explain in a bit more detail the way that we think about our eligibility information. So hopefully folks are seeing slide 9. When we think about our eligibility and the way that our program is structured across the quality payment program, we have clinicians who could be eligible for MIPS, but they may not be eligible for an alternative payment model. But what we want clinicians to think about is really all clinicians start off as being MIPS eligible, and then we can further subset out whether or not a clinician would be excluded from the MIPS program due to a reason. So for example, it could be that a clinician is excluded from MIPS due to not meeting our low volume threshold, but it also could be that a clinician could be excluded from MIPS if they achieve a QP status or partial QP status. In those circumstances, though, those clinicians would still be considered MIPS eligible and APM participants. They just have slightly different scoring rules. And let's move on to slide 10. Okay, thank you. So on slide 10, I wanted to talk just a bit about our alternative payment models and the different types of APMs that we have. So APMs, there are multiple different types of APMs we have available, including APMs that may be focused on a health condition or a population or an episode of care. And we also have broad types of APMs, including our overarching alternative payment models. Then we have APMs that we classify as MIPS APMs, as well as advanced APMs. And I do want to be really clear that the designation of an APM does not affect a clinician's eligibility for a MIPS. It's rather that an APM participant would still need to participate in the MIPS program unless they receive QP status or are otherwise exempt. And we have one more slide, if we move on to the next slide, that will hopefully make this really clear to folks. If there are still outstanding questions, we'd be happy to take questions at the end. So again, when you think about the way that you would participate in the quality payment program, we have our broad set of MIPS eligible clinicians, and then of the MIPS eligible clinicians, there are certain clinicians that are APM participants. And an APM participant could be participating in a MIPS APM or an advanced APM. Only those MIPS eligible clinicians that are an APM participant that also participate in an advanced APM and achieve QP status are fully exempt from the MIPS program. If you are an APM participant and you achieve partial QP status, you then have a choice on whether or not you could participate in MIPS or if you would be exempt. Again, there are a few other ways that you could be exempt from the MIPS program, which I'll touch on a little bit later on the presentation here today. But as we think about the two tracks of the MIPS program, I did just want to provide some further clarity on how we see the tracks, where we see alignment, and then where we see areas where there may be some differences. And with that, let's move on to the next slide, and I will turn the next portion of the presentation over to Sophia Sugamar to talk through our MIPS value pathways proposals. Sophia?
Thanks, Molly. Next slide, please. All right, so to get us started on our MVP-related proposals, one of the first areas we want to touch upon is our MVP implementation timeline and what participation would look like in the MVP space. So one of our first proposals is that we are proposing for MVPs to be implemented gradually, and the first year that they would be available for reporting, it would be the 2023 performance year. For the first 2 years of MVP reporting, which is 2023 and 2024, if finalized as proposed, we are proposing a new term, and that new term is MVP participants. And that term is meant to encapsulate the following clinician types: individual clinicians, single specialty groups, multi-specialty groups, subgroups, which we'll get to in a little bit later, and APM entities. Another area of the MVP proposed timeline that we've laid out in the proposed rule is a timeline in which, starting with 2025, multi-specialty groups would be required to form subgroups in order to report MVPs. And that's really to get us to a point where clinicians within a group are really reporting on measures that are more meaningful to their direct practice and maybe not so relying on the performance of a few clinicians of the group, but rather than really having data they can utilize to make quality improvements in the care they provide to the patients. And we are seeking comment, just a side note here, we did not make this an official proposal, but we are seeking comment on the eventual sunset of the traditional MIPS program. And we have laid out in an effort to be transparent, that we would like to end, ideally, the traditional MIPS pathway begin after the 2027 performance period and the associated data submission period. Any formal proposal related to the sunsetting of traditional MIPS would have to happen in formal future rulemaking. So this is more of wanting to understand our stakeholders' concerns or any kind of barriers that you might face, any additional items that we should consider when we consider future proposals for the eventual sunset of traditional MIPS. Next slide, please. In the previous finalized rule for the 2021 performance period, we had established a set of MVP development criteria. Within this proposed rule, what we're attempting to do is update some of the development criteria to really align with some of the additional proposals we have put forward related to reporting requirements. And so with that, we have proposed to add the following MVP development criteria, which is that MVPs must include at least one outcome measure that is relevant to the MVP topic, so that MVP participants are measured on outcomes that are meaningful to the care they provide. The requirement for an outcome measure or a high priority measure when an outcome measure is not available is something that most MIPS eligible clinicians are familiar with. It is something that is considered a requirement under traditional MIPS, so we are planning to carry that into the MVP space here, and with that would want to make sure that there are outcome measures available as feasible within the MVP for clinicians to report. With that, we understand and we talk about MVP structure a bit in the proposed rule. So a given MVP may be attributed to one specialty or several specialties. So if in an instance an MVP is attributed to several specialties, perhaps it's created and implemented in a manner that emulates the team-based care model where there are several specialties involved. We would want to make sure that each MVP has at least one outcome measure that is relevant to each clinician specialty that is included within that given MVP. So if an MVP is made up of surgeons and anesthesiologists, we want to make sure that there is a relevant outcome measure available for each of those specialties to report on. And we are aware there might be instances where outcome measures may not be available. And so in those instances, we would like there to be the inclusion of a high priority measure that is relevant to the MVP topic so that the MVP participants can be measured on the high priority measures in instances where outcomes are not available. In the previous final rule, we had finalized additional administrative claims-based measures that were classified as outcomes-based measures. We are identifying in some instances that those outcome-based measures may be appropriately used with an MVP as a part of the quality component of the MVP, as in one of the potential measures that given clinician can report or be calculated on. And so we will allow, when appropriate, the utilization of those outcomes-based, administrative claims-based measures within the quality component of the MVP. That's not to say that it's a requirement of all MVPs, but when it's there and it's applicable, it can be used. Looking at the next criteria, that again touches upon, that again touches upon the availability of high priority measures when an outcome is not available. And the last is more of a reminder with the utilization of QCDR measures in MVPs, that the QCDR measures must be fully tested at the clinician level prior to the MVP being finalized and available for the upcoming performance period. Next slide, please. So with the establishment of the MVP development criteria and the implementation of MVPs, we anticipate that in order for us to understand the uptick of MVP reporting and also be tracking to who would we be providing this enhanced performance feedback, which we'll get to in a minute, we want to establish a registration process. So with MVP registration, MVP participants would register between April 1st and November 30th of the same performance year to report an MVP. So for example, for the 2023 performance period, MVP registration would begin on April 1st, 2023 and end on November 30th, 2023. We have built out some flexibility in case there is a inadvertent circumstance that we are unplanned for, which would cause us to expand the registration time period. So it may be a later date as specified by CMS, but for the time being, we are planning for there to be a consistent time period of April 1st to November 30th. The one thing we want to account for is that there may be MVPs that include the CAPS or MIPS survey measure, and that measure may be one that is relevant and meaningful to an MVP participant. And so we are aware that the CAPS or MIPS survey has their own separate deadline, and so for that reason, we want to make sure we align with or have the capability to align with the CAPS or MIPS survey timelines. And so for those that intend to report the CAPS or MIPS survey measure, we would ask that they complete their MVP registration by June 30th of the performance year, and that's to align with the CAPS or MIPS registration deadline that's already established. So to register, an MVP participant would have to identify the MVP they intend to report, and within the foundational layer of the MVP, one of the population health measures included in the MVP. We have proposed for the MVPs that they include 2 population health measures, and so essentially MVP participants will be given a choice as to which of the 2 population health measures they'd like to be calculated on, and any outcomes-based administrative claims measure within the quality component of an MVP. So if it's available within the MVP they choose to report, and they like to have that they'd like to be calculated on that measure and have it count as one of the 4 quality measures they would be reported on for the quality performance category, they'd have to identify that at the time of registration. MVP participants could only make changes to their MVP elections during the registration period, so up until November 30th. After that November 30th deadline, we will not be able to accept any additional changes. We will not be able to allow for the reporting of an MVP that a given MVP participant did not register for. And so for more additional information related to the registration process, we refer you to the resources on the QPP Resource Library, including the fact sheets. Next slide, please. This slide, we're focusing on specific policies that affect third-party intermediaries. So for QCDR's qualified registries and health IT vendors, we are proposing that they support MVPs that are relevant to the specialties they support beginning with the 2023 performance period. And this is to really acknowledge that not all QCDRs, qualified registries or health IT vendors, support all specialties. Some are very specialized, and so we want to allow them to have some flexibility to only support MVPs that are relevant to the clinicians they actually provide services to. In addition to that, we have also proposed to require that QCDR's registries and health IT vendors support subgroup reporting beginning with the 2023 performance year. And in addition to that, require that the CAPS for MIPS survey vendors support subgroup reporting for the CAPS for MIPS survey measures specifically associated with within an MVP beginning with the 2023 performance year. For that last item, it's more so that when the CAPS for MIPS survey measure is included in an MVP, if a subgroup would like to report that measure, they should be able to do so. And so we want CAPS for MIPS survey vendors to be prepared to support that capability. It's not a requirement that you report on the CAPS for MIPS survey measure, but since it's there as an option, we want to make sure that MVP participants can report on that. Next slide, please. Okay, and so this slide here, we summarize in total the number of MVPs we have proposed, which is 7. They cover various topics. We are proposing, again, that these MVPs be available beginning with the 2023 performance year, and they cover the topics of rheumatology, stroke care and prevention, heart disease, chronic disease management, emergency medicine, lower extremity joint repair, and anesthesia. We've worked collaboratively with a lot of stakeholders on this, and we hope that you all find these MVPs very interesting. I do refer you to the proposed rule, the appendix, where we include the details of each of these MVPs, including which measures and activities we propose to include in each. Through the MVP development process, we do plan to gradually implement additional MVPs for additional specialties and subspecialties that participate in the program. And we're looking at this process as an incremental approach and look to hopefully continue the MVP development process over the next few years to slowly grow our library of MVPs. Next slide, please. Okay, this slide, I know there's a lot going on here. This is an example that we wanted to visualize with for you. This is the anesthesia, patient safety and support of positive experiences with anesthesia MVP that we have proposed in this 2022 PFS proposed rule. You'll note that there are several quality measures, improvement activities, a cost measure listed in this specific slide. I do want to emphasize that with MVPs, we are not expecting that clinicians report on every single measure and activity within the MVP. And so with that, if you look at the quality measures, for example, we would expect, or we are proposing that the reporting requirements be that a given MVP participant would report on 4 quality measures, one of which should be an outcome measure or a high priority measure if an outcome measure is not available. You will note that this specific example includes QCDR measures. If a given MVP participant would like to report on a QCDR measure, you must sign up with a QCDR to utilize their measure. So you would need to do that in order to report those measures. With the improvement activities, our proposed reporting requirements are that you select 2 medium-weighted activities or report on 1 high-weighted activity, and that is all you're required to report. So we offer this list of relevant activities that are relevant and meaningful to this topic and allow you to have some choice as to which ones you would like to report on. For the cost measure aspect of the MVP, there is no choice there. Those are automatically calculated. Cost measures don't require data submission. So we will calculate those cost measures to the extent we can. If there is an instance we cannot calculate a given cost measure, we have proposed reweighting policies that would cover us in those instances in which the weight would then be reweighted to quality. Next slide, please. And this is really the bottom layer of all MVPs. We call this the foundational layer. It is MVP agnostic, so that means that it is the same across the board, regardless of the clinical topic of a given MVP. And it includes the 2 population health measures, one of which is the hospital-wide 30-day all-cause unplanned readmission measure, and the other being the clinician and clinician group risk standardized hospital admission rates for patients with multiple chronic conditions. These 2 measures are utilized at administrative claims-based collection type. And we would ask all MVP participants to identify which of the 2 population health measures they would like to be calculated on at the time of MVP registration. For the promoting interoperability aspect of the foundational layer, the same requirements for reporting under traditional MIPS will carry over into the MIPS value pathways. We are not creating separate reporting requirements for promoting interoperability under MVPs. I will just note that whatever exemptions that currently exist for certain clinician types under PI will carry through in the MVP space as well. We are not creating separate exemptions under MVP policies. Next slide, please. Okay, and so I won't go into detail, but these slides are provided to provide a reference of the diagram I just went through and the reporting requirements for all 4 performance categories and the foundational layer. Next slide, please. The next slide or 2, we're going to get into the subgroup policies that we have proposed. And so we are proposing to define a subgroup as a subset of a group which contains at least 1 MIPS eligible clinician and is identified by a combination of the group TIN, the subgroup identifier, and each eligible clinician's NPI. Participation in a subgroup. With regards to participation, we are limiting subgroup reporting to only clinicians who report through MVPs or the APM performance pathway. Voluntary reporters, often eligible clinicians, and virtual groups wouldn't be able to report to MIPS through an MVP for the 2023 performance year due to implementation challenges. We did see comments on this, so if there are input that you would like to provide, we encourage you to do so through the formal comment period. The requirement to participate with regard to subgroups for the 2023 and 2024 performance years, it would be voluntary. We have proposed, when we previously discussed the timeline, that starting with 2025, that subgroup reporting would be mandatory for multidisciplinary groups. And that is really to get down to more meaningful reporting, that, having clinicians report directly on measures that are attributed to them and thereby getting more valuable results that they can actually act upon. And that is really our intent with subgroups. And so we're hoping with requiring multidisciplinary groups to do that, we can move to increase the value of the program. With regards to subgroup eligibility and special statuses, subgroups will inherit the eligibility and special status determinations of the affiliated group, even if the subgroup composition wouldn't meet the criteria. So to participate as a subgroup, the TIN would have to exceed the low volume thresholds at the group level. We would not be evaluating subgroups for the low volume threshold at the subgroup level. The registration process for a subgroup, it coincides with the MVP registration process. So April 1st to November 30th of the performance year or a later date as specified by CMS. The subgroup would complete their CAPS or MIPS survey registration as applicable by June 30th of the performance year for those that are interested in reporting on the CAPS or MIPS measure. To participate as a subgroup, each subgroup would be required to identify the MVP. The subgroup would report along with the population health measure included on potentially any outcomes-based admin claims measure for which the subgroup intends to be scored on. Or they need to also identify the clinicians within the subgroup by TIN NPI and also provide a plain language name for the subgroup for purposes of public reporting. And we would assign, based off of that information through the registration process, we would assign a unique subgroup identifier upon successful registration. Next slide, please. With regards to MVP scoring, we're going to start with the quality performance category. Quality measure scoring is in alignment with traditional MIPS for the most part. We have a slide reference to 38 and 39, which we'll get to a bit later. We are removing the 3-point floor for quality measure scoring. That is consistent with what is proposed for traditional MIPS. We are introducing a new policy for scoring measures without benchmarks, and also parallel proposals under traditional MIPS to not include bonus points for reporting measures that are high priority or using the end-to-end electronic reporting bonus. Similar to quality scoring reporting within traditional MIPS, we would use the 4 highest scored measures if an MVP participant reported more than the required number of measures. If an MVP participant would receive 0 achievement points for the quality performance category for any required measure that wasn't reported. If an outcome-based admin claims measure is available and selected by the MVP participant to fulfill the outcome measure requirements, the measure would receive 0 achievement points when the measure doesn't have a benchmark or meet the case minimum. Next slide, please. With regards to costs, the cost scoring would align with those used under traditional MIPS. Only the cost measures that are included in the MVP selected by the MVP participant would be scored. With regards to improvement activities, each medium-weighted improvement activity would be assigned 20 points, while each high-weighted improvement activity would be assigned 40 points. And for IA, it's that you either have to do 2 medium-weighted activities or 1 high-weighted. With regards to the foundational layer, the population health measures that is selected by the MVP participant would be rolled up into the quality score. Similar to the administered claims measure policies under traditional MIPS, these measures would be excluded from scoring if the measure doesn't meet the benchmark or case minimum. The exception to that is that the subgroups would receive the score of the population health measure of their affiliated group, if applicable, in the event that the measure selected by the subgroup does not have a benchmark or cannot meet the case minimum. For promoting interoperability, measures are scored in alignment with traditional MIPS. And one note here is that subgroups would be using their promoting interoperability score from their affiliated group. They would not be scored at the subgroup level. Next slide, please. With regards to final MVP scoring, the performance category weights would generally align with that of traditional MIPS, the category weights, which we'll get to in a bit. The reweighting policies would also align with traditional MIPS, the only exception being that the quality performance category would not be reweighted if we cannot calculate a score for the MIPS eligible clinician because there isn't at least one quality measure available or applicable to the clinician. We are proposing that MIPS eligible clinicians would receive the highest final score available to them from any reporting option and participation option with the exception of virtual groups. Virtual groups will always receive the virtual group's final score. And that is to say that if a given MIPS eligible clinician chooses to report a MIPS value pathway, but then also decides to submit data through the traditional MIPS means, both will be calculated and the highest score will count as their final score. Next slide, please. And I touched upon enhanced performance feedback earlier and the need for registration in order to track and monitor as to which measures and MVPs we would be providing this feedback for. We are proposing to provide comparative feedback within the annual performance feedback to show the performance of similar clinicians who perform and report on the same MVP. With regards to public reporting, we are proposing a delay of a new improvement activities and promoting interoperability measures and attestations reported through MVPs by 1 year. We would publicly begin reporting subgroup level performance information beginning with the 2024 performance year on the Care Compare tools hosted by us, CMS. And we're also proposing that subgroup performance information be publicly reported separately from the individual clinician and group performance information. And for additional information there, I refer you all to the QPP proposed rule guidance and resources that are available through our website. And with that, moving on to the next slide, I will turn it over to Brittany Lacouture for the APM performance pathway proposal.
Thanks, Sophia. Next slide, please. So I hope this is good news for everyone. This year we have very, very few changes to the MIPS reporting and scoring rules for APM participants. In the APP, the only proposal that we have is to extend the use of the CMS web interface into the 2022 performance period. We heard you all loud and clear in the feedback we've gotten from stakeholders that they were just not prepared to move fully into the ECQM, MIPS, CQM reporting for the 2022 performance year. So we are extending the web interface into 2022, exactly the same as it has been for 2021. The other part of this proposal is that we would also keep the web interface for the 2023 performance year, with the caveat that in order to be scored on the CMS web interface, you would also need to report on at least one ECQM or MIPS-CQM in order to trigger the web interface scoring. And really the point of that is to encourage people to take that leap forward into using the all-payer measures and the digital measures, because that's really the direction that CMS is trying to go in this quality program. I do want to reiterate that, as is the case in 2021 and would be for 2022, in 2023, if you report on your ECQM or MIPS-CQM and the web interface, because you would have to report on both in order to be scored on the web interface, when we have both of those measures scored, we would give you your quality performance category score based on whichever is higher. So if you submit the web interface and you submit the ECQM and you do better on the ECQM, you will have your score based on that performance. And if you do better on the web interface measures, we would base your score on that performance. And so it's, the idea is that there's no risk. Go for it, try, see how you do. That way, when we do truly sunset the web interface for 2024, hopefully it won't be your first time attempting to report on these ECQMs. You'll have experience, you'll know what scoring will look like, and everyone will feel really prepared to go into this new form of reporting to MIPS. So that's all that I have on the APM side for 2022. Like we promised, we're trying to keep the APP constant with as few changes as possible to try to create a little bit more stability for our APM participants so you guys can really focus on the work that you're doing within your APM. So let me turn it back over, and I think it's going back to Molly.
Thanks, Brittany. And let's go ahead and move on to slide 29, please. Okay, so now that everyone has heard our proposals related to MIPS value pathways and the updates related to the APP, I wanted to reorient us back to our, as we've called it, our traditional MIPS program and our policy updates there. So just as a reminder, the MIPS program is a program that assesses clinicians' performance under 4 distinct areas. I do want to clarify these 4 performance categories are required by law, and they include quality, the measurement of quality, the measurement of cost, improvement activities, which deals with continuous improvement within an organization, and promoting interoperability, which focuses on the usage of certified EHR technology. As you can see on this slide here, each of those 4 categories have a weight associated with it, and that sums up to a total of 100 points. That becomes important because we assign to each clinician under the MIPS program something called a final score, which is based off of your performance on these 4 distinct performance categories. I'll talk about this later on in the presentation, but just to flag it now, the performance threshold that we have proposed for calendar year 2022 is 75 points. So what that means is that clinicians whose final scores fall below 75 points would get a negative adjustment, meaning a penalty and a reduction in your claims, so less money. If your final score is above 75 points, you would get a positive adjustment or more money on your claims. And if your final score is at 75 points, you would get a neutral adjustment. Again, I'll talk through this in much more detail later on in the presentation. Let's go ahead and move on to the next slide, where I just want to talk through the performance category weights in a bit more detail. As you've heard us talk about in our presentation today, as well as our presentations over the past year, we have introduced some new terms when we think about the quality payment program, including traditional MIPS and our MIPS value pathways, and then the APP and how those performance category weights work. So as you can see on this slide here, the gray columns are our performance category weights for traditional MIPS for 2021. So as you can see there, the performance category weights for individuals, groups, and virtual groups for quality and cost was 40 and 20%, improvement activities and promoting interoperability 15 and 25. For APM entities in 2021, quality contributed 55 points, cost was re-rated, and improvement activities was 15 and 30 points respectively. Jumping over to the APM entity proposed changes for 2022. For 2022, the proposed change is 55 points for quality, 0 for cost, and then 15 and 30 for improvement activities and promoting interoperability. And then under the APP, which does apply to individuals, groups, and APM entities, we're proposing to have the quality weight contribute 50 points, cost still re-weighted to 0, and improvement activities and promoting interoperability at 20 and 30 points respectively. For all clinicians that are not participating under the APP or not part of an APM entity, their performance category weights would be 30 points each for quality and cost, and then 15 and 25 points for improvement activities and promoting interoperability. Let's move on to the next slide with proposed revisions to the set of MIPS eligible clinicians. So we have proposed to expand our set of MIPS eligible clinicians to the last 2 clinician types that the law allows us to expand to, which includes clinical social workers and certified nurse midwives. So assuming this policy is finalized, we would have full expansion of our MIPS eligible clinicians. And with that, let's move on to the next slide, and I will turn the presentation over to Lisa Marie Gomez to talk through our quality proposals. Lisa Marie?
Thanks, Molly. So for the next few slides, I'm going to review the various proposed policies for the 2022 performance period that regard the quality performance category under traditional MIPS. Next slide, please. So now I'm going to discuss the quality performance category collection types that are available. For the 2021 performance period, groups and virtual groups would be able to use electronic clinical quality measures, also referred to as ECQMs, Medicare Part B claims measures, MIPS CQMs, QCDR measures, and CMS web interface measures. In the 2021 Physician Fee Schedule final rule, we finalized that the CMS web interface would no longer be an available option starting with the 2022 performance period. However, in the 2022 Physician Fee Schedule proposed rule, we are proposing to extend the CMS web interface as a collection and submission type through the 2022 performance period, in which the CMS web interface would sunset starting with the 2023 performance period. Next slide, please. For the 2022 performance period, we are proposing a total of 195 quality measures, which include substantive changes to 84 existing quality measures, changes to quality sets, removal of measures from specific specialty sets, removal of 19 quality measures, and the addition of 5 quality measures, including 2 administrative claim measures, shown on this slide, which regard risk standardized acute unplanned cardiovascular related admission rates for patients with heart failure, and the risk standardized hospital admission rates for patients with multiple chronic conditions. Also, I want to note that as part of the proposed rule, we issued a request for information regarding the draft COVID-19 vaccination by clinicians measure specifications. So we also request for you to review that and submit comments. Next slide, please. Now I'm going to discuss the quality measure benchmarks. In the 2021 Physician Fee Schedule final rule, we did not finalize our proposal to use performance period benchmarks exclusively for the 2021 performance period. However, in the 2022 Physician Fee Schedule proposed rule, due to the extreme and uncontrollable circumstances policies that were in effect for the 2020 performance period, we are proposing to use performance period benchmarks for the 2022 performance period or a different baseline period such as calendar year 2020 or 2019, pending analysis of the 2020 performance period data. Next slide, please. Now I'm going to discuss data completeness. So in order to meet the data completeness criteria for the 2021 performance period, performance data must be reported for at least 70% of the denominator eligible encounters. The data completeness threshold of at least 70% will be maintained for the 2022 performance period. For data completeness, the volume of performance data reported for the measure's eligible population. So when reporting a quality measure, you must identify the eligible population, which is the denominator, as outlined in the measure specifications. Incomplete reporting of a measure's eligible population or otherwise misrepresenting a clinician or a group's performance, so only submitting favorable performance data, commonly referred to as cherry picking, wouldn't be considered true, accurate, or complete, and may be subject to an audit. Also, I want to note that we are proposing to increase the data completeness threshold to 80%, starting with the 2023 performance period. Next slide, please. Now I'm going to discuss the quality measure scoring. So for the 2021 performance period, we did not establish new scoring policies for new measures. Our previously established policy of awarding 3 points to measures without a benchmark continued to be applied. For the 2022 performance period, we are proposing to establish a 5-point floor for the first 2 performance periods for new measures submitted that meet the data completeness requirement. In regard to measures with a benchmark, our previous established policy of a 3-point floor continued to apply for the 2021 performance period. For the 2022 performance period, we are proposing to remove the 3-point floor. Thus, measures would receive 1 to 10 points. In regard to measures without a benchmark, so these measures without a benchmark, whether historical or performance period, will earn 3 points for the 2021 performance period. For the 2022 performance period, we are proposing to remove the 3-point floor except for small practices. Measures will receive 0 points and small practices would earn 3 points. Next slide, please. So now I'm going to discuss measures that do not meet case minimum requirement of 20 cases. So such measures would receive 3 points for the 2021 performance period. For the 2022 performance period, we're proposing to remove the 3-point floor for measures that do not meet the case minimum requirement. Measures would receive 0 points. Small practice would earn 3 points. So in regard to the high priority bonus points, the reporting of additional measures receive bonus points if data completeness and case minimum requirements are met for the 2021 performance period. An outcome or patient experience measure receives 2 bonus points, and a high priority measure receives 1 bonus point. For the 2022 performance period, we are proposing to remove bonus points for the reporting of additional outcome and high priority measures beyond the 1 required. In regard to the end-to-end reporting bonus points, each measure that meets the end-to-end electronic reporting criteria will receive 1 bonus point for the 2021 performance period. Measures do not need to meet data completeness or case minimum in order to receive the end-to-end electronic reporting bonus. For the 2022 performance period, we are proposing to remove the bonus points for measures that meet the end-to-end electronic reporting criteria. Next slide, please. Now I'm going to discuss the quality scoring flexibilities. So for the 2021 performance period, we increased previously scoring flexibilities by expanding the list of reasons that a quality measure may be impacted during a performance period, and revising our policy to determine when to allow the scoring of a measure that is truncated or suppressed if 9 months of data is not available. For the 2022 performance period, we are proposing to expand the list of reasons that a quality measure may be impacted to include errors, including changes to the active status of codes, inadvertent omission of codes, or inclusion of inactive or inaccurate codes. Next slide, please. Now I'm going to discuss the quality scoring for groups reporting Medicare Part B claims measures. For the 2021 performance period, we automatically calculate a quality performance category score at the individual and group levels when Medicare Part B claim measures have been reported by small practices. For the 2022 performance period, we are proposing only to calculate a group level quality score for Medicare Part B claims measures if the small practice submitted data for another performance category as a group, signaling their intent to participate as a group. We recognize that not all small practices that report Medicare Part B measures intend to participate as a group. Now we will transition to slide 41, and I'm going to turn the presentation to my colleague, Joel Andres. Joel?
Thank you, Lisa Marie. Good afternoon, everyone. My name is Joel Andres, and I am the cost measure lead here at CMS. I'm going to discuss briefly the changes proposed for the cost performance category. Next slide, please. Thank you. The total per capita cost measure, the Medicare spending per beneficiary clinician measure, and the 18 existing episode-based cost measures remain in place as per the final rule in 2021. We have proposed 2 changes relevant to the cost category. The first listed here is the inclusion of 5 newly developed episode-based cost measures. These include 2 procedural measures that address melanoma resection and colon and rectal resection, a single acute inpatient measure addressing sepsis, and 2 of our first chronic condition measures addressing diabetes and COPD. Next slide, please. Thank you. The second proposal that we've presented in the proposed rule for this year is the implementation of an external cost measure development process and a call for cost measures with an expectation for earliest adoption in 2024, in the 2024 performance period, I should say. We've built the criteria and requirements for measures being considered for submission to the MUC list and for inclusion in the program based upon the criteria we've subjected our internally developed measures to, so that the standards applied to those measures will be applied equally to externally developed measures. But this will have the effect of allowing measures developed outside of CMS to be considered for adoption within the cost category of the MIPS program. And now I'll turn the presentation over to Michelle Peterman for a discussion of the improvement activities category.
Thank you, Joel. Like Joel said, my name is Michelle Peterman. I am the improvement activities lead, and I will be walking us through a few of the key improvement activities proposals. Next slide, please. So the first policy we're going to talk about is the removal of an IA during the performance period. We do not currently seek to address removal of IAs during the performance period. This issue came to our attention last year when we found out that one of the IAs had become obsolete after the proposed rule had been published. Since improvement activities must be removed through rulemaking, we felt this was no way to immediately remove the obsolete activity. We needed to wait till the following year's rulemaking, which meant the IA would need to stay in the program another year, even though it was no longer available to complete. So in order for us to allow flexibility to suspend IA performance year, we are proposing a policy that would allow us to do so a safety concern or if they become obsolete during the performance year. When this issue arises, our proposal is to alert stakeholders that a particular IA has been suspended from the program through listserv messages, and then we would subsequently remove the IA from the QPP website as it would not be available for the attestation for the next year. Next slide, please. The second policy that we're going to be discussing is revising the criteria for nominating an improvement activity through the call for improvement activities process that we have each year. Our current policy is that it only requires one of our criteria to be met in order to submit a nomination for a new improvement activity. When we began the program with this threshold to assist stakeholders in understanding these criteria, so we believe that now we need to go ahead and increase the requirement since stakeholders have had the chance to become familiar with the criteria and understand how to submit a new IA. So what we are proposing are that there would be 8 criteria that are required, 6 which are on our current list, and 2 which are new we are proposing. We believe these should be the foundation for all improvement activities. At the bottom of this slide, there is a link, and all the criteria may be found at the link. Below it's provided at, it says 2022 QPP proposed rule comparison table. The very first 12. I'll walk through them very quickly. The 6 that we are from our old list that we are still maintaining and want to have as required are relevance to an existing improvement activity subcategory. Second, the importance of an activity toward achieving improved beneficiary health outcomes. Third one, feasible to implement, recognizing its importance in minimizing burden for small practices, rules, and areas designated as HIPSAs. And fourth, evidence supports that an activity has a high probability to contribute to improved beneficiary health outcomes. Fifth, that it can be linked to existing and related MIPS quality, promoting interoperability and cost measures. Sixth, CMS that we're able to validate the activity. There are 2 new criteria that we are adding, which this would be the number 7 of the 8, which is does not duplicate other improvement activities in the inventory. We receive a lot of nominations, and a lot of them are very similar to or could be incorporated in an existing improvement activity, and so we don't want activities that we already have in the inventory. It would make our inventory too burdensome and large. And then our final criteria is that it should drive improvements that go beyond purely common clinical practices. What we mean by common clinical practices are things that are typically done in the practice, for example, taking a patient's vital signs. We want improvement activities that go beyond that and are, innovative and are driving improvement. Next slide, please. Lastly, we are proposing just a few changes to the IA inventory. We're adding 7 new improvement activities. Of those, 3 are related to promoting health equity. We're modifying 15 current improvement activities. 11 of those address health equity, and then removing 6 previously adopted activities. These are mostly incorporated in the modifications. We're just streamlining the inventory. And that about wraps up the IA proposals. I will now pass the presentation over to Elizabeth Holland, who will be discussing and promoting interoperability policies.
Thank you, Michelle. Next slide, please. This is Elizabeth Holland, and I'm the Promoting Interoperability Lead at CMS. First, we're going to talk about reweighting. As you see in this central column, we currently reweight all these different clinician types, and we propose to continue and extend that into 2022. We are also proposing to extend the automatic reweighting to clinical social workers. We did not propose to reweight the certified nurse midwives because of their experience with our measures through the Medicaid Promoting Interoperability, or EHR incentive program. We are changing our policy for small practices. Currently, small practices are required to submit a significant hardship exception application in order to be reweighted. And we understood that many small practices qualified for this, but they were not actually completing an application. So our proposal is to automatically reweight small practices. We will identify the small practices on the CMS side, and then you would be automatically reweighted. If the small practice chooses to submit data, that data will be scored and you will not be reweighted. Next slide, please. Now to discuss our public health and clinical data exchange objective. Right now, we give clinicians a choice of submitting to 2 of the 5 registry reporting options. In the proposed rule, we are modifying this mainly due to the data needed to address the pandemic. So we are going to require the immunization registry reporting and the electronic case reporting. I will note that both of these registry reporting options do have 3 exclusions. So if you qualify for one of those exclusions, you could claim that. And in addition, we are offering bonus points, 5 bonus points if you submit to one of the other 3 remaining registry types, the public health, the clinical data registry, or the syndromic surveillance. Next slide, please. So we have a couple more modifications for promoting interoperability. One is for the provide patients electronic access to their health information measure. We're proposed to require patient health information remain available for patients going forward and back with a service date of January 1st, 2016. We think this is important for patients to have a longitudinal record of their health information. We are also requiring one of the safety assurance factors for EHR resilience guides, or SAFER guides. We're going to require a review of the high priority guide. In addition, we are modifying our information blocking attestation statements. Currently, there are 3 different statements that you need to attest to, and we're proposing to remove 2 of them. Next slide, please. Now I'm going to turn it back over to Molly McHarris.
Thanks, Elizabeth. And let's go ahead and move on to the next slide, where I will wrap up the rest of the proposals for the MIPS program. Okay, great. So starting with our revisions to the complex patient bonus. So there's a number of proposed revisions we have here. First, I wanted to flag that we have made a proposed revision to the complex patient bonus for this performance period, for the 2021 performance period, 2023 payment year, to double the bonus points again. So similar to what we did last year, where we doubled the complex patient bonus points due to the indirect effects of the COVID-19 public health emergency, we've again proposed to do that for the 2021 year. We also have made a number of proposals to revise our methodology for calculating the complex patient bonus, really to ensure that we are providing the right incentive to those clinicians who see the most vulnerable and medically complex patients. So those proposals consist of limiting the bonus to clinicians who have a median or higher value for at least one of the 2 risk indicators. Again, we use HCC scores and proportion of dual eligible beneficiaries. We also are proposing to update the formula to standardize the distribution of 2 risk indicators. And we also are again proposing to increase the cap on the bonus from the current cap of 5 points to a proposed cap of 10 points. Those items I just covered are proposed revisions, again, for next year's complex patient bonus for the 2022 year. Let's move on to the next slide. Okay, so just a few additional updates for our redistribution policies. So as I went over earlier in the presentation, you'll recall each performance category has a designated weight available to it. Myself and my other colleagues, for example, you all just heard Elizabeth talk about circumstances where we may not be able to calculate a performance category for a clinician or a group of clinicians. And so, for example, under the promoting interoperability performance category, we have a number of reweighting exceptions available for certain types of clinicians. So when a performance category gets reweighted, we still have to move those points. So typically promoting interoperability counts for 25 points. We need to move those to another performance category because the law requires us to always assess a clinician's performance based off of a total point scale of up to 100 points. So what we have decided to do for this year is to revise our reweighting and redistribution policies, particularly for small practices, to ensure that those small practices can have a more equitable playing field. So in circumstances when the promoting interoperability performance category is reweighted for small practices, quality would count for 40 points, cost for 30 points, and improvement activities for 30. In circumstances when both promoting interoperability and cost are reweighted, so again, assuming we finalize our small practice automatic reweighting policy as proposed, and if there are instances where we can't calculate cost, a small practice's final score would be assessed off of the weights of quality of 50 points and improvement activities for 50 points, assuming we finalize as proposed. Okay, let's move on to the next slide where I want to start talking through the performance threshold. So as I mentioned earlier, we have established or we have proposed our performance threshold for next year, calendar year 2022, to be at 75 points. Also, as I mentioned earlier, this is the year that the law requires us to establish the performance threshold based off of a prior year's data period, as well as using a methodology of the mean or median. And so we have proposed to use the mean methodology, and we have proposed to use the first year's data that we had available to us, which was calendar year 2017. As an aside, when we looked at all of the available data periods, we actually found that 2017 had the lowest available final scores that we could select from. So using that mean methodology and using that data period, we have a proposed performance threshold of 75 points and a proposed additional performance threshold of 89 points. And let's move on to the next slide where I will talk through this in a bit more detail. One item I do want to flag is that 2022 will be the last year that we have our additional performance threshold for exceptional performance. So looking at the right-hand side of the slide, and I'm going to start at the green row in the middle. So 75 points, that's our performance threshold we have proposed for this upcoming year. Going down the table, you can see that clinicians whose final scores fall below that would get a negative payment adjustment, so then less money on your claims. For those whose final scores are anywhere between 0 and 18.75 points, so for example, if you decide you just don't want to participate in MIPS, you would get a negative 9% reduction on your claims during the 2024 calendar year. If your final score, again, is anywhere between 18.76 points and 74.99, it would be a negative adjustment, but it would be on a linear sliding scale. For those whose final scores are above the performance threshold of 75 points, they would get a positive adjustment. And again, those whose final scores are above 89 points would get the additional performance threshold. And again, 2022 is the last year that we have that set of bonus money available. Okay, and that's everything that we have for MIPS. So let's go ahead and move on to the next slide. And then the next slide again, and I'll just briefly talk through our public reporting proposals for the doctors and clinicians tool on the Care Compare website. So first, we have a proposal to expand our facility affiliations. Right now, we currently publicly report hospital affiliations on clinician and group profile pages, and we are looking to expand those affiliations to include all of the facility types that are listed on slide 58. And we also are soliciting comment on the appropriate number of procedures or conditions treated at a given facility that we should have that linkage. So again, we are looking for feedback on that proposed policy. And let's move on to the next slide, slide 59, with just a few additional proposals and comment solicitations I wanted to touch on. So first, and I'm going to start at the bottom of the slide first, as Sophia mentioned earlier when she went over our MVP proposals, we are proposing to make revisions to how we publicly report our information to account for MIPS value pathways. So we are proposing to delay public reporting of new improvement activities and promoting interoperability measures and attestations that are reported via an MVP by 1 year. We also would begin publicly reporting our MVP information and our subgroup level information on the Compare Tool website. And we also are proposing that the subgroup performance information would be publicly reported separately from the current individual clinician or group profile pages. We are also soliciting comment on ways to further expand the type of utilization data that could be added to the Care Compare website. And we also are soliciting feedback on ways where we can publicly report more information on APMs or under the APP in future years. And that is everything we have for public reporting. So let's move on to the next slide, and I'll turn the presentation back over to Brittany to talk through our advanced APM proposals. Brittany?
Thanks, Molly. Next slide, please. Again, we're very light on APM proposals this year. In the 2021 final rule, we finalized really a description of how we choose which TIN to make the APM incentive payment to. In that rule, we talked about how we look at TINs based on claims that are submitted during the base year, which is the calendar year that immediately precedes the payment year. Based on us having a little bit more experience with making these payments, we've identified a means of also using data that comes in during the payment year to also help us identify TINs to make that payment. And so in this proposed rule, we are proposing to use claims data from both the base year and the payment year to help us identify an appropriate potential payee TIN to receive the APM incentive payment, which sounds very long and complicated, but the gist of it is that we found a way of getting those payments out a little bit faster. So that's what that proposal is about. Not listed here because it's not a proposal. We are codifying the statutory change to the QP thresholds, which came about through the Consolidated Appropriations Act of 2020, which was this past December. And it froze the QP thresholds at the current levels, so they'll remain at 50 and 30% for the 2021 and 2022 performance periods. So that's also in this regulation, but it is a statutory or statutorily mandated change to our regs. So just so you're aware that that's in there. And that's it for me. And I will pass this along to my colleagues representing the Shared Savings Program. And I think we have Stephen to describe these new proposals to you.
Hi, Brittany. This is Sandra Slaughter. Thank you, Brittany.
Sorry, Sandra.
No problem. I will provide an overview of the Shared Savings Program proposals. Next slide, please. The Shared Savings Program finalized the following policy in the 2021 PFS final rule. For performance year 2022 and subsequent performance years, ACOs would have been required to actively report quality data on the 3 ECQMs, MIPS CQMs via the APP and field the CAPS for MIPS survey. CMS will calculate two measures using administrative claims data. Since the CY 2021 PF rule was issued, stakeholders have continued to express concerns about requiring ACOs to report ECQMs, MIPS, CQMs via the APP due to the cost and purchasing and implementing of a system-wide infrastructure to aggregate data from multiple ACO participant TINs and varying EHR systems. We believe the updates we are proposing to the reporting requirements under the APP are responsive to stakeholder requests to delay the requirements that ACOs report all-payer ECQMs, MIPS, CQMs, while still providing incentives for ACOs that are ready to report the ECQMs, MIPS, CQMs. We are proposing that for performance year 2022, that an ACO will be required to report on either the 10 measures under the CMS web interface or the 3 ECQMs, MIPS, CQMs. An ACO will be required to field the CAPS for MIPS survey, and CMS will calculate two measures using administrative claims data. Based on the ACO's chosen reporting option, either 6 or 10 measures will be included in calculating the ACO's quality performance score. For performance year 2023, an ACO will be required to again report either the 10 measures under the CMS web interface and at least one of the 3 ECQMs, CQMs, or the 3 ECQMs, MIPS, CQMs. Again, an ACO will be required to field the CAPS for MIPS survey, and CMS will calculate two measures using administrative claims data. CMS will only score the CMS web interface measure set for an ACO that has also submitted at least one ECQM, MIPS, CQM. Then for 2024 and subsequent performance years, an ACO will be required to report on the 3 ECQMs, MIPS, CQMs, and field the CAPS for MIPS survey. CMS will calculate two measures using administrative claims data, and all 6 measures will be included in calculating the ACO's quality performance score. Additionally, we are clarifying that the CAPS for MIPS minimum sampling thresholds also apply to shared savings program ACOs. Next slide, please. On this slide, we describe the proposed quality performance standard for shared savings program ACOs for performance year 2022 and subsequent years. As part of our intent to gradually phase in full reporting of ECQMs, MIPS, CQMs, we are proposing to include incentives to encourage early adoption of full ECQM, MIPS, CQM reporting prior to performance year 2024. We are proposing that for performance year 2022, an ACO that reports the 10 CMS web interface measures, if the ACO receives a quality performance score that is equivalent or higher than the 30th percentile across all MIPS quality performance category scores, excluding entities and providers eligible for facility-based scoring, then the ACO would meet the quality performance standards. For an ACO that reports all 3 ECQMs, MIPS, CQMs, if the ACO meets data completeness and case minimum requirements for all 3 ECQMs, MIPS, CQMs, and achieves a quality performance score equivalent to or higher than the 30th percentile of the performance benchmark on at least one measure in the APP measure set, then the ACO would meet the quality performance standard. For the 2023 performance year, the quality standard is the same as for 2022. However, if an ACO does not report at least one ECQM, MIPS CQM, then the ACO would not meet the quality performance standards in 2023. And for 2024 and subsequent performance years, an ACO that reports all three ECQMs, MIPS CQMs, if the ACO achieves a quality performance score that is equivalent or higher than the 40th percentile across all MIPS quality performance category scores, excluding entities and providers eligible for facility-based scoring, then the ACO would meet the quality performance standard. In the proposed rule, we are also soliciting comments on several topics related to addressing health disparities and promoting health equity, the feasibility of PIN-level reporting and sampling for ECQM, MIPS CQM, reporting options for specialist providers within an ACO, and publicly displaying prior year performance scores that equate to the 30th and 40th percentile MIPS quality performance category scores. We encourage you to review these sections of the rule and submit comments. And now Katie will review help and support.
Great. Thanks, Sandra. All right, everybody. Thank you so much for hanging in there with us. I know this is a lot of information. Maybe stand up, take a stretch before we get to QA. Real quick here on this slide, we just always like to remind folks that you are in a small and solo practice. We do have our SIRS technical assistance available to you at no cost. So there's information on how to contact them if their assistance would be helpful to you. It's a really great resource. And as always, we have our QPP website with a resource library and a lot of other tools on our different QPP pages to help you participate in the program. And we always have our QPP Service Center agents available by phone and email to answer your questions as well. And we have our CMMI, so Center for Medicare and Medicaid Innovation Learning Systems as well. Next slide, just one more quick reminder. I know we've said it several times, but September 13th is the date to remember that all comments on this proposed rule need to be submitted formally through this formal process. And with that, I am going to turn it back over to our Ketchum team so that we can go over some information on how to participate in our Q&A session. So thanks, everybody.
Great. Thank you, Katie. All right. So to ask a question, thank you for the next slide. So to ask a question over the phone line, please go ahead and dial the number shown on your screen and press *1 to be added to the question queue. And we will be taking live questions today. Otherwise, please continue submitting your question over the chat box, and we will go ahead and read them out loud. So while we wait for a few questions to be queued up, we do have a few on the chat box already. So to begin, for the CMS web interface, if the CMS web interface is used for reporting in the 2022 performance year, does a 70% data completeness requirement still apply?
Hi, this is Sandra from the Shared Savings Program. The CMS web interface, when ACOs or groups report, they report on a sample of Medicare beneficiaries, and the requirement is that they report on the first 248 consecutively sampled beneficiaries, or all beneficiaries in the sample if there are fewer than 248 patients in the sample.
Okay, wonderful. Thank you for that. Stephanie, do we have any questions on the phone line?
We have a question from Jason in Shropshire.
Hi, can you hear me?
Yes, we can hear you.
Yes, can you please go over again how a multi-specialty TIN is going to work with MVPs? And I'll give you an example. If I have a TIN that is comprised of, a tax ID that has 15 different specialties, are each one of those specialties going to be required to report a set of quality measures themselves? So meaning if I have 15 specialties, I'll probably have to be reporting like 60 quality measures as a TIN or tax ID.
Sure. So this is Sophia. With regards to your question, what we have proposed is with MVPs being proposed for implementation beginning with 2023, that this groups and multi-specialty groups can report on MVPs for the first 2 years. We also allow for subgroup reporting, which allows those multi-specialty groups, for example, that are made up of 10, 15 specialties, to voluntarily choose to split out in multiple subgroups to then report on the MVP and really report on measures that are relevant to them within a given MVP. So for the first few years, it's voluntary. We have proposed within the timeline beginning with 2025 that multi-specialty groups, if they choose to report an MVP in 2025, they would have to do so by forming a subgroup. So we have not specifically called out in the group, in the policies that a subgroup must be made up of a single specialty, or whether we can allow for multiple specialties. That is an area that we are requesting comment on, the composition of subgroups, and whether there is value in allowing that multi-specialty approach within the subgroup beginning with 2025. So we are there are some flexibilities for the first few years. We do note that simultaneous to the MVPs and subgroup policies being implemented, we will continuously have, we are proposing to have traditional MIPS continue forward with a potential future where there will be an eventual sunset of that part of the program. But for the time being, we have laid out several options to allow for flexibility and allow clinicians to then have some time to orient themselves to MVPs and MVP policies to prepare for the eventual implementation of subgroups and MVP reporting.
Okay,
Great,
so
thank
to
you.
confirm, in 2025, it doesn't seem quite clear to me yet what you're saying, that if a TIN has several specialties, each one of those specialties would have to report their own set of quality measures. Can you say yes or no or confirm that?
So yes, with the policy that we've proposed in 2025, a multi-specialty group would, in order to report an MVP, and a multi-specialty group would have to form subgroups. We have not explicitly said in the rule, this is an area we're seeking comment on, that each of those subgroups must be of a single specialty. The area of subgroup composition is an area we are choosing to address in the future rulemaking processes. We would like to receive some comments, formal comments from stakeholders as to what would be considered the best approach, or if there are any concerns with a given approach when we consider the subgroup composition in the mandatory state in 2025, if finalized as proposed.
All right, thank you.
Great, thank you. All right, moving on with the Q&A. Can you please confirm for the promoting interoperability performance category, for the proposal to require immunization registry reporting, would providers need to have a bidirectional immunization interface in order to attest this registry type?
No, bidirectional is not required for immunization registry reporting.
Great, thank you. Okay. Next, can you please confirm for the complex patient bonus how it applies to APMs? Does the bonus apply to all participants in an ACO, or only those clinicians who have a median or higher value for the indicators?
Sorry, which bonus was this asking about?
This is for the complex patient bonus.
The complex patient bonus for APM entities is applied at the APM entity level, so we will do the calculation of your score based on all of the participants within the entity, or the ACO in this case.
All right. Next question. Are health IT vendors required to support MVP reporting starting in the performance year 2023, even if it is optional?
Yes, that is the proposal. It specifically states third-party intermediaries, QCDRs, qualified registries, and health IT vendors would be required to support MVPs that are relevant to the specialties that they support. We are aware that there are certain third-party intermediaries that only cater to certain specialties, so there is not an assumption that you must, as a third-party intermediary, support all MVPs, but we would like third-party intermediaries to help encourage the utilization of MVP reporting.
Great, thank you. Stephanie, are there any more questions on the phone line?
We have a question from Jennifer Gasparini.
Hi, yes, thank you. First, I wanted to say thank you to CMS for being responsive to ACO concerns about the timeline for moving to ECQM reporting. We're very pleased to see the proposals to provide that additional time, so thank you for that. I did have a few questions. I'll just pick one to start with, but for the CAPS for MIPS survey, which is applied to ACOs, are you sampling ACO patients only?
Hi, this is Sandra from the Shared Savings Program. The sample would be from patients that are assigned to the ACO.
Okay, thank you.
Great, thank you. All right, Stephanie, do we have any more questions on the phone line?
No other questions at this time.
Okay. All right, next question. Can you please clarify the proposed end of traditional MIPS? Is it after the 2027 performance year or during the 2027 performance year? Can you please clarify that proposal?
Sure. And just to clarify, it's not a formal proposal. It's an area that we're seeking comment on. Any future consideration or formality of letting the public know that we would like to sunset traditional MIPS in a certain year will have to be done through future rulemaking. So we are planning to lay out the timeline, starting with 2023 is when MVPs will first be implemented and available for reporting. For 2023 and 2024, subgroup reporting will be available, but it's optional. Beginning with 2025, if you are a multi-specialty group, we are proposing that the only way you could report an MVP is by forming subgroups. And then we have solicited comment in this proposed rule, that in 2027, after the 2027 performance period and corresponding data submission period, we would sunset traditional MIPS. Therefore, the remaining option that would be available and would thereby lead to MVP reporting to become mandatory would be that starting with 2028, MVP reporting is mandatory for all. It replaces traditional MIPS.
Great, thank you. All right, we have time for just a few more questions. Can you please confirm that performance year quality benchmarks that are released during that performance year are also used to score measures being reported on in the same year?
Lauren, could you repeat the question?
Yes. So can you please confirm or clarify that performance year quality benchmarks that are released during one performance year are used to score measures that are being reported on in the same year?
Yes, that is true. So when we release the reason why the reason why I asked you to repeat it is because we don't typically release our performance period benchmarks until after we have gone through our assessment and scoring. But to answer the question, we will release our performance period benchmark. So for example, for the 2021 or for the 2020 year, we will release our performance period benchmarks that were used to for those measures that did not have a historical benchmark available. So those will be released and I hope that helps clarify.
Great, thank you. All right, and I think we have time for one more phone question. Stephanie, are there any questions on the phone line? Stephanie, are there any questions on the phone line?
We have a question for Therese Kaig.
Hi, to echo a couple of other folks, thanks for hosting this. This is very helpful. I have a question regarding forming an MVP subgroup. Will that be self-identified, or will that be driven by some indicators such as like your specialty code and PACOS? Or could you comment on how you think those are going to be formed? Thank you.
Sure. So the subgroups are not ones that CMS would create, or they're ones that would allow groups to self-identify and create the subgroups. The subgroups should be derived from a group, and we would ask that in order for a subgroup to be considered a subgroup, you would provide several types of information at the time of subgroup registration, and that would include which MVP you would intend to report, and also who you would identify to be a part of the a part of the subgroup. You would have to list out the 10 NPIs as a part of the subgroup registration. You'd also have to assign a subgroup name to your subgroup. There are certain and we need to be tracking that information. So because there are certain parts of the MVP reporting where we rely on the group score, for example, promoting interoperability. So we need to be able to tie back that subgroup of clinicians to the essentially the parent group. So there are certain needs of information. I'm sure when we get closer to the time of implementing this process of registration, we will have additional resources that outline subgroup formation and also the how to register and the steps to register. So more additional information should be coming in the future.
Thank you.
Okay, and I believe that's all the time we have for today. So Katie, we'll turn it back over to you to conclude.
Great, thanks Lauren, and thanks everybody so much for joining us today. Just a reminder that our slide deck as well as our transcript and recording will be available in the next couple of weeks on our QPP webinar library. And if you haven't done so already, please sign up for our QPP listserv. It's where we send out all of our most up-to-date information about the program. And thanks, we'll talk to you next time.